Medurstand. Understanding Medicine.
Professor Aziz-ur-Rehman with another video, and this time we are going to cover atrial fibrillation. And if you remember, in the last video we discussed atrial flutter, and this time a very similar, relatively more common and relatively more serious condition called atrial fibrillation. The difference is that in atrial flutter, atrial contractions occur at the rate of approximately 300 per minute. But in atrial fibrillation, you can't really tell because you don't see P waves at all, but approximately 500 plus. So there is so fast atrial depolarization that atria actually practically do not contract at all. So atria are standstill. Atrial depolarization is passing in all random directions, and atrial wall is maybe just thrilling, fibrillating, just moving, but no active contraction at all. So, and this arrhythmia is much commoner than atrial flutter, and you need to learn this even more important. We have covered atrial flutter and today atrial fibrillation. So this is it, and this is again going to be a short video because we are not going to, we have already discussed basic concepts. So today I'm going to just focus on the fibrillation. Examine this ECG. This is 12 lead ECG from a person who is a known case of ischemic heart disease and complains of palpitation. Now, if you see the 12 leads 1, 2, 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. No infarction, no ischemia, no bundle branch block, no hypertrophy. But when you study the rhythm step, there is a problem. Now you please study a QRS complex and always you study this continuous strip from left to right. What do you see here? Do you see QRS complexes? I'm going to mark them for you. You could even otherwise appreciate the QRS complexes, but I have marked them to make it easy. What is the first thing you notice? The first thing you notice, or you should notice, is that they're very, very irregular. No adjacent RRs are equivalent. These two may be equivalent, but then every RR is different because QRS complexes are irregularly irregular, right? These are the QRS complexes. And for any rhythm analysis, you need to see the QRS and you also need to see the P wave. And let's look for the P wave. Where is the P wave? Let's scan our ECG again from left to right very slowly. Please follow this. Do you see any P wave? These waves are actually T waves corresponding to the previous QRS complex. So there isn't any P wave at all. So throughout this recording, there is no P wave. So we have noticed two things. RR are irregular, irregularly irregular. No two adjacent RRs are equal. And there is no P wave at all in this lead. And you remember that P wave is best visible in limb lead 2 like here or V1 or V2. There is no P wave in V1 or V2. In fact, there is no P wave anywhere. So there is no P wave. That is the hallmark of atrial fibrillation. So some of the observation, atrial rate we can't tell because we don't see atrial contraction, atrial depolarization. Ventricular rate we have to calculate by counting the QRS complexes in certain time interval and then multiply it with. Like I did it for 10 seconds. These 10 large squares or 10 into 5, 50 small squares, there is 10 seconds. And since 10 is 1/6 of a minute, then we multiply with 6 and we get the heart rate 106, 108. This is slightly variable because if you count from another part of strip, it might be different, slightly different, because it is irregularly irregular. There is tachycardia, but the rhythm is irregularly irregular. Okay, irregularly irregular means that there is no predictability. Like in atrial flutter, there was some irregularity, but you could tell that after third or fourth beat, one QRS complex is going to be dropped. But here you cannot predict at all because every adjacent RR is irregular. And this would translate into irregularly irregular pulse. When you examine the pulse of this patient, because pulse is produced by the QRS complexes, it would be exactly as irregular as these R waves are. The QRSs are narrow, of course, because this is supraventricular tachyarrhythmia. In supraventricular tachyarrhythmia, AV node and the rest of the conduction system is not affected unless there is another reason. So if there is no other reason, then QRS complexes would be narrow, like normal person. So I think the diagnosis is very, very clear, atrial fibrillation. And the diagnostic criteria I have listed here. Number one, no P wave. Please make sure that you are looking at the right leads, limb lead 2 or limb lead, precord lead V1, V2 must be examined. Of course, you have to examine all the leads before you say that there is no P wave. And don't confuse P wave with the T wave of the previous complex. Any P wave has to correlate with the following QRS complex, not the previous one. Okay, so that is it. And then RR interval is very, very irregular. RR is very irregular and narrow QRSs, and ventricular rate is from 50 to 300. Why so? Because it is variable. Now, if you calculate it here, it may be 300, and if you calculate it here, it may be 250, and somewhere else it may be 300. Because in atrial fibrillation, there is always variable block because atria are bombarded with so many depolarizations that AV node is almost all in a constant state of depolarization. This is called concealed conduction. Most of the atrial depolarization will penetrate AV node and will die off there because most of the AV node will be in the refractory state. It would not be allowed to pass. So most of the atrial depolarization will die within the AV node. Only an occasional, only a random atrial depolarization will be allowed to pass into the ventricles. That is why we have irregularly irregular rhythm. I hope you have learned how to diagnose atrial fibrillation. Typically, patient has got very fast heart rate, and typically when you examine it, it is irregularly irregular, and when you do ECG, you don't see any P wave and you see irregularly irregular RR intervals. And the QRS complexes are narrow. If they're broad, you might as well look for some ventricular arrhythmia, unless there is right or left bundle branch block or rate limited aberrant block or pre-excitation syndrome. I might show you one or two examples of pre-excitation syndrome also. Now this is what actually already explained. In the atria, there is not one re-entry cycle, there are numerous re-entry cycles and all are random, like I think stampede. Just imagine stampede. In stampede, everybody is running around in this direction, that direction, wherever possible, and many fall down, and only occasional would be, I think, able to get out of that place. I think this is a good example, stampede. In atrial fibrillation, there is stampede, and only occasional depolarization will be allowed to pass into the ventricle. This is another case. What do you see? If you see the limb lead 2, of course, the complexes are broad in this case. There could be another reason, and if you look at V1, there is typical morphology of right bundle branch block. So this patient has got right bundle branch block. So whatever arrhythmia you have to see this patient, consider right bundle branch block as an additional pathology. Now what do you see here? P waves. Again, I have marked, you see the arrows, you could tell from the RR also, but I guess with these arrows, this abnormality become more obvious. Now, this is the period where you could see P wave. Do you see any P waves? No, you don't. These small deflection may be called fibrillation waves or small f. When we refer to fibrillation wave, we use the small f, and when we refer to the flutter waves, we use the uppercase f, the large f. So maybe you can say these are small P waves, but I'm not sure. I think you could call them P waves. But you can't really tell the difference, and you can't determine the heart rate. So as far as I'm concerned, there is no P wave. Okay? Even if these are waves, but they're not P waves. Then already mentioned pre-existing right bundle branch block. So the diagnosis is atrial fibrillation with the right bundle branch block. Now it is not uncommon at all. Right bundle branch block is a fairly common condition, and atrial fibrillation is also not rare. So if you're talking about two relatively common conditions, they can coexist. So this right bundle branch block is there, but what needs your attention and why this particular ECG is here for discussion is atrial fibrillation. You also see that T wave inversion and ST depression. This could be because of the right bundle branch block, or I would definitely consider coexisting ischemia in this patient. So atrial fibrillation with the right bundle branch block, one example of broad complex irregular tachycardia. What do you see here? It is atrial fibrillation. Now, something very rare we see called Ashman phenomenon. And this is perhaps Ashman phenomenon. Ashman phenomenon says that in atrial fibrillation, sometime if a beat comes little earlier than expected, and it was actually preceded by a longer RR interval, which is not exactly the case here. If this RR was longer and this RR was a little shorter, then one supraventricular depolarization might conduct as right bundle branch block pattern. We call it Ashman phenomenon. So maybe this is Ashman phenomenon, or patient has atrial fibrillation there and there are some VPCs. So there may be some problem with the ventricle also. These may be ventricular depolarization, but I think more likely these are supraventricular fibrillation waves but conducted as right bundle branch block pattern, indicating Ashman phenomenon. Now this is fast atrial fibrillation and very broad complexes. You see, this would initially, if you look at this ECG, initially your impression would be ventricular tachycardia. We haven't yet covered ventricular tachycardia, have we? No, we haven't. Yes, we are going to cover it. So ventricular tachycardia or ventricular fibrillation, this ECG, I think my first impression would be ventricular tachycardia. Why? Because it is broad and it is very fast. That is a typical feature of ventricular tachycardia. But there are two things which tell me that this is the atrial fibrillation. One is it is irregularly irregular. See, it is irregularly irregular. And you don't see any P waves, and patient was clinically stable. In ventricular fibrillation, ventricular tachycardia, patient is usually hemodynamically compromised, and you also do not see what is called precordial concordance. This I will explain when I discuss ventricular fibrillation. So I know that this is atrial fibrillation and it is fast, it is broad, because this patient had Wolff-Parkinson-White syndrome. We have already covered that some patient with Wolff-Parkinson-White syndrome, if they have antegrade conduction through the anomalous pathway, antegrade means from atria to ventricle from the anomalous pathway, patient may have SVT with broad complex, or patient may have atrial fibrillation with broad complex. So this is one example. This patient would be considered much more serious than other person with simple atrial fibrillation. This patient should be offered the most effective treatment, and the most effective treatment in such cases would be electrical cardioversion. So rate is 198 beats per minute. Rhythm is irregular, and QRSs are broad complexes, and it should be treated with cardioversion. A, B, C, D should be avoided. A is adenosine, B is beta blocker, C is calcium channel blocking agents, and D is digoxin, because all these drugs, they slow down conduction through the AV node and can actually promote or can accelerate conduction through the anomalous pathway, and the ventricular rate may actually increase. Heart can beat at 198, but if it goes further up, the patient is going to be in trouble. There could be further ischemia, myocardial damage. So I think this patient should be treated with direct electrical cardioversion. And I say within 48 hours. If patient had history of palpitation of less than 48 hours, it may be safe to straight away go with electrical cardioversion. But if it is longer, then first we have to anticoagulate. I cannot go into the detail because we're not actually discussing the management. That hopefully we will cover sometime later. But today we are covering only the ECG. So this was a fast atrial fibrillation with Wolff-Parkinson-White syndrome. What do you see here? Is it atrial fibrillation? R irregular, and there is some waves, maybe flutter wave or fibrillation. Here you don't see any waves. Here you see the waves. So this is perhaps flutter fibrillation, and it is relatively slow. I would call it slow atrial fibrillation oblique flutter. Okay, that is what I would label it. So it's slow. If you examine the pulse, it might not be very fast, but it will be irregular. That is the hallmark of atrial fibrillation. And why do we have slow RR? This could be effect of some drug. Maybe this patient is being treated with digitalis or beta blocker, or there is some additional disease in the AV node that could cause slow atrial fibrillation. And some basic facts: atrial fibrillation, it could be paroxysmal or acute or chronic. Paroxysmal, which comes and goes, patient gives history of many attacks. Acute, which is just recent onset, or chronic, which is established. There is different treatment approach in different cases, so that's why I brought up this topic into discussion. Then in the treatment, we have rate control strategy or rhythm control strategy. Again, I will just only be briefly touching it because we're not discussing management. In rate control, you try to control the rate by giving beta blocker or digoxin or calcium channel blocking. In rhythm control, we try to restore normal sinus rhythm. And this would be possible only if patient has a relatively short history and there is no underlying disease like rheumatic heart disease or something like that. Patient have 5 times more risk of stroke. So that makes it very important condition. Patient may be minimally symptomatic, but it gives very high chances of developing stroke. So these patients would require long-term anticoagulation. Luckily now we have very effective anticoagulant drugs, safe ones also, they should be given. And in some patient, if somebody is young, and then radiofrequency ablation or catheter ablation may be attempted, and the response to these procedures is very good, provided you are in good hands. So in good hands, I think this could be very rewarding. I hope I was able to give you some good insight into understanding of atrial fibrillation. So that completes today's module. Professor Aziz-ur-Rehman from Medurstand-Understanding Medicine. I look forward to see you in my next video, and let me assure you that this module on ECG is going to end in just maybe 1 or 2 weeks. If you are willing, then we can have a Zoom meeting to discuss various, I can take your questions, and if you like, we can continue with another topic, maybe lab evaluation, maybe radiology, maybe whatever you want me to do. Thank you very much. I am at your disposal. My reward is my own satisfaction. I don't expect any monetary reward. Thank you very much for watching this video.